Go ahead.
Good afternoon. I'm Dr. Dale Bratzler. I'm the Enterprise Chief Quality Officer here at OU Medicine and the University Chief COVID Officer. Going to provide an update on where we're at in the state with respect to COVID-19. I apologize for doing it on a Thursday, but have to work from the Norman campus tomorrow. COVID-19 cases, of course, continue to rise, and I will be sending out a handout that will have information on it. Today they've reported 1,085 new cases in the state. We're up over 95,000 cases in Oklahoma now, and I expect by next week we'll be over 100,000 cases in our state. The State Health Department reported 10 new deaths today. When you look over the past week, there's been just over 7,000 new cases confirmed in the state of Oklahoma and 44 additional deaths that have been confirmed in the past week. Our 7-day rolling average, the number of new cases that we see on average daily, remains above 1,000 cases a day. As I've highlighted in the last couple of weeks, the one thing that's very clear is that COVID-19 and the new cases in our state have moved to the rural communities, the rural counties. So when you look at the actual population incidence of COVID-19, many of the rural counties actually have more cases per population than we see even in our metropolitan areas, even though the metropolitan areas will have the most cases simply because they have the largest populations. But we've seen many counties in our state see outbreaks in an increased number. And again, it just highlights for me that we're still seeing consistent community spread of COVID-19 in Oklahoma now. The testing in Oklahoma continues to go very well. There are many tests being done, although I know that the state still has unused capacity to be able to do more tests. As of yesterday, about 9.7% of the tests that were run yesterday or reported yesterday were positive, so that remains relatively high. And then, of course, the one statistic that I've been monitoring since the start of the pandemic that everybody is talking about right now is hospitalizations. As of yesterday, we were at 697 people in the hospital. There were 245 confirmed cases of COVID-19 that were occupying ICU beds in the state. I know there are a lot of questions about hospitalization and capacity. There has been some movement of a few patients around because of some concerns about capacity. And of course, the hospital that got a lot of attention in the last week was Stillwater Medical Center, where they actually had to open up additional beds to accommodate their patients. Oklahoma in general still has hospital bed capacity, but we do have limitations with respect to staffing, particularly nurse staffing, and so that is a concern. And again, right now we're okay. Hospitalizations are down just a little bit from the peak just a few days ago, but I just keep wanting to point out that should we see early flu season, and we're already seeing a few cases of influenza that have been confirmed in Oklahoma this year. If we were to see an early outbreak of influenza and it generated a lot of hospitalizations, we could get our hospitals into trouble in a hurry in terms of capacity, and would have to move to relatively aggressive surge plans that might restrict types of activities, elective activities and other things, which delays patient care. It's frustrating to patients if they're planning elective operations, if they need cancer screenings and other things. Those are very important, and I think all of us in the healthcare community have a real concern that because there have been real delays in things like cancer screening, that we may see upticks in cancer, particularly more advanced cancers in the future. In the handout that I'll be sending out, I highlighted 4 different studies this week that I thought were interesting. The first is just a brief description of monoclonal antibodies. This got a lot of press attention this week because when the president had the diagnosis of COVID-19 confirmed, one of the first treatments he received was what was called the antibody cocktail, which is a cocktail of 2 monoclonal antibodies made by the company of Regeneron. Essentially, what are monoclonal antibodies? Monoclonal antibodies are man-made antibodies that are specifically designed to attack certain proteins or organisms. So it's doing something that the immune system would typically do, but making high concentrations of those antibodies and injecting them. It's part of the whole concept behind convalescent plasma. When somebody recovers from COVID-19, donates blood, we take their plasma. Their plasma should have antibodies against the virus that causes COVID-19. Well, this purpose of using monoclonal antibodies is that the only antibodies that you're giving the person now are those against COVID-19, and you can give much higher concentrations. So Regeneron and the other company in the United States, Eli Lilly, have both developed monoclonal antibodies against the virus that causes COVID-19. At least in the very, very preliminary studies, recognizing that neither of these are FDA approved yet, they've been shown to reduce viral load fairly substantially after they're given. Right now they're not broadly available. I'm not aware of any clinical trials in Oklahoma at this time with monoclonal antibodies because there are limited supplies of monoclonal antibodies at this time, and they remain very, very expensive. The second study I thought was quite interesting was one where they took a group of healthy volunteers and a group of patients, they were all from a VA, who had severe chronic obstructive pulmonary disease, or COPD, and they put them in a surgical mask and exercised them. And the good news is that they did not see any reductions that were significant in oxygen in either group, the healthy or those patients with COPD, and they did not see any retention of carbon dioxide. So again, they highlight that we should not let this unsubstantiated claim that wearing a mask might impair your ability to breathe stop this very, very important public health practice, which has been shown to slow the spread of COVID-19. The third study I highlighted this week was one that was just published recently, and it was done in healthcare workers. So primarily healthcare workers who are routinely exposed to patients with COVID-19. So frontline workers in the emergency room, in the intensive care unit, nurses, doctors, respiratory therapists that might be working with COVID patients who are on a ventilator. That group of healthcare workers were randomized to either receive placebo or to receive hydroxychloroquine, the anti-malarial drug that was originally touted as a possible cure or prevention for COVID-19. And in that study, which was terminated prematurely, they found no difference in the COVID infection rates in people who were taking placebo versus those that were taking hydroxychloroquine. Because these were healthy healthcare workers in general, they didn't have any serious side effects, but the people who were taking hydroxychloroquine did have some additional complaints of some side effects. And then finally, the last one was an interesting paper that was published by the Centers for Disease Control and Morbidity, Mortality Weekly Report. I think many of us remember that it was just weeks ago that Arizona was having a huge outbreak in the number of COVID-19 cases. And what this particular article does is systematically walk through all of the interventions that they did very systematically to get this particular outbreak under control, because they were overwhelming their hospitals very quickly. And it included the things that I think most of us know have been successful at stopping the spread of the virus. Of course, they put into place mask mandates, they closed bars, gyms, they limited capacity in restaurants, they didn't close them, they shut down movie theaters, and they put these restrictions into place and saw a relatively quick reduction in the overall spread of the virus. Finally, just for Oklahoma, I just want to completely reiterate that the engine of spread of COVID-19 in Oklahoma right now are young people. They're the people who are most commonly getting infected. People in that age group of 15 to 24 and 25 to 38 have the most new cases in our state. But the people who are suffering the consequences of COVID-19 are people who are over the age of 55. Patients 55 and older in Oklahoma account for 93% of the deaths from this disease. So again, I think it's really, really important that we continue to inspire our young people to wear masks, to practice social distancing. Even though they don't get as ill, they're the ones who eventually are likely to be spreading this disease to the older population who's suffering the consequences, who's being hospitalized, and who's dying from the disease.
Excellent. Obviously, we have a lot of hospital questions. You've answered a lot, so I tried to sift through those, and I'll ask you a few of the others that are related. And you probably have to repeat the question because I bet from this distance they can't hear me very well. What is the average stay for someone with COVID?
Yeah, so in Oklahoma, it depends on whether or not, first let me just say that when a person gets COVID-19, in general, we try to keep the patients at home, unless they're having difficulty breathing or other complications of the disease. Most people with COVID-19, probably 90% or a few more, don't need to be in the hospital. That's the good news. They may be ill, they may have shortness of breath or cough, fever or other symptoms, but they can be treated at home with just symptomatic therapy, and they don't need to be in the hospital. But of that group of patients who do need to be in the hospital, by far the most common reason is that their blood oxygen is low. And those patients typically, if they're not very ill, have an average hospital length of stay of about 4 days according to the health department, but that range is anywhere from 1 to 15 days per the health department. For people, though, who are very ill and subsequently die of the disease in the hospital, the average time, from the day they get admitted until their death is only 10 days. Typically, they're very ill and they go downhill quite rapidly, but that varies substantially, going from anywhere from 2 days all the way out to a month in the hospital before they die. And of course, that's the 90th percentile. There are a few patients who may even have longer hospitalizations than that. So I think it's important to recognize that if you're sick enough to end up in a hospital in our state, most likely, those are the patients who have complications and have higher risk of death from the disease, obviously.
So do you think that the patients then that are, you say it can go up to 30 days or maybe even a little bit more on somebody who's in the hospital before they pass, I mean, would that have something to do with how fast they were brought to the hospital to begin with? I mean, maybe they got sicker or they didn't get as sick and so they were brought in early and they stayed longer?
Yeah, so the question is why are some people in the hospital for longer periods of time or others that come in very sick and die rapidly? And I think I heard a quote this past week. The one thing that is consistent about COVID-19 is that we cannot predict how any individual person will do. Some people do just fine and recover rapidly. Some people do well for a while, looks like they're getting better, and then suddenly crash, probably because their immune system activates and starts causing all of that organ damage, particularly lung damage that we hear about. Some people have a slow progressive course, have neurologic symptoms or other organ systems involved, and can have prolonged hospitalizations. So it's very unpredictable. Once that person is sick enough that they're in the hospital, it's very difficult to predict what their course may look like.
Okay. Can you just make a statement about how if people should be concerned with the amount of COVID cases every day and the uptick in hospitalizations across the state? Just kind of a overarching.
Well, I think we're still seeing 1,000 new cases being confirmed each day. And if you look at Oklahoma data, anywhere from 8 to 10% of those people end up in a hospital, and a smaller percentage of those end up in an intensive care unit. And because of that, we're going to continue to see deaths from this disease. I was looking at data earlier today on just the number of deaths in Oklahoma. Remember, the very first case of COVID-19 was confirmed somewhere around March 6th, as I recall. If you count the number of days since March 6th to today, and you take the number of deaths we've had and divide it by those number of days, how many of us would have predicted or told Oklahomans that on average, 5 Oklahomans are going to die every single day since the first day of this pandemic through the first week of October. I don't think it's just a different way to think about the perspective of those numbers, but we're seeing a lot of new cases, and like it or not, we're seeing just under 5 deaths per day in Oklahoma on average since the start of this pandemic. Of course, we didn't see a lot of deaths at first. Now we're seeing more. Today, 10 more deaths were reported.
Rebecca at KOKH was, when you had mentioned about the flu season starting up, and she asked this question, if flu season hits and hospitalizations get worse, could we be at risk for future shutdowns? How many hospitalizations would we need to reach for our hospitals to be overwhelmed?
Yeah, so that's a really good question. The question is, how many people would we have to have surge into the hospital, whether from influenza or COVID, before the hospitals have to go into shutdown? And I can't give you an exact number, because all of the hospitals have contingency plans in place for surge capacity. But I think it's important that people understand what that actually means. It means bringing in community practitioners. It means bringing in nurses that may have been retired for some time. It means finding additional healthcare workers to actually take care of those patients in the additional surge capacity. It's not like we just have extra nurses and extra doctors sitting around not doing anything right now in our healthcare systems. And so there are real concerns about things such as quality of care and other things should we get to that capacity. So that's why at the worst end of surge capacity is that you shut down everything elective, but that means people who are trying to get cancer screenings and other things, preventive services, don't get them while you're in that shutdown. So it has a real public health consequence itself. So by far the message I want to get out, the best thing we can do is slow the spread of the virus and slow the spread of influenza. Wearing a mask will do both. Getting your flu shot will dramatically reduce the number of influenza cases or the severity of the cases that we see. And then hopefully within a few months we'll start to see distribution of a vaccine against the SARS-CoV-2 virus that causes COVID-19, and we can see a slowing in the number of new cases from COVID-19. The reality is, though, we're just not seeing much slowing. We're still seeing 1,000 new cases a day in our state.
Dylan, and you talked about this a little bit, but just maybe to reiterate, Dylan at KOCO was asking what sorts of people are in the hospital. Is it almost entirely older people, or are people being transferred from nursing homes?
Well, so what are the types of patients that are in the hospital? I think it's a combination. So as you know, the number of young people is relatively small. So of that 15 to 24 age group, which represents the largest group of people right now who get COVID-19 on a daily basis, only about 1% of those people, that age group, ever get in the hospital, which is good news. Younger people are less likely to be hospitalized. By far, though, when you get up to 65, 75, 85, a substantial proportion of those people who get the infection do end up in the hospital, and that's where most of the deaths are. I think I quoted earlier that 90.3% of all of the people who die in Oklahoma from COVID-19 are age 55 and over. Now, 55 is looking younger to me every day, but 55 and older are the number of people that actually are at greatest risk of death from this particular disease. Yes, some of them are from nursing homes, but not necessarily. Parents, grandparents, and other people that get exposed to a young person have ended up in the hospital. They're not necessarily all from nursing homes by any means anymore. Of course, we saw the large outbreaks of cases in correctional facilities, and again, many of those people are younger, so the hospitalization rate isn't high, but it's not zero. Some of those people that were in the correctional facilities have actually been hospitalized.
Okay, what's a COVID ICU like, and what is it like for a patient in the COVID ICU?
Well, of course, it depends on what, how sick they are, but most of the patients, if they're in the intensive care unit, are going to be on some form of supplemental oxygen. It's not uncommon to require assisted ventilation, maybe not being on a mechanical ventilator, but having some type of assisted ventilation with something we call BiPAP or others to help them get more oxygen into their lungs. There's obviously treatment. We try to not keep the patient with too many fluids or anything which could cause problems with their lungs. If they're that sick today, typically they're going to get some of the treatments that are available, such as remdesivir, the antiviral medication that's given intravenously, and certainly if their oxygen is low, if they're having trouble breathing, they're going to be placed on corticosteroids, which have been shown to reduce mortality, particularly in the people who are bad enough to get on mechanical ventilation. Of course, mechanical ventilation is kind of the last stage of treatment, and then one other form of therapy that's only available in the largest hospitals would be extracorporeal membrane oxygenation, where you take blood out of the person, run it through an artificial lung to get oxygen into the blood, and then give them that blood back, essentially replacing the lungs with a machine to get more oxygen in their system. So there's a range of things that happen to these patients who end up in the intensive care unit, and it's difficult to predict up front which patient may need which therapy. The good news is today that there are some forms of therapy that actually been shown to work, reduce length of stay, reduce death rates from the disease, which we didn't have at the first of the pandemic.
You mentioned the length of stay averaged for people that pass or that have COVID in general, but can you just kind of touch on that a little bit more, and maybe specifically some of the people that are here for several weeks, they end up being able to go home and they don't pass?
Yeah, absolutely. So what I provided you was ranges of time that people are typically in the hospital. So a person who doesn't die, who does go home, the average length of stay in Oklahoma hospitals is only 4 days, but the range up to the 90th percentile is up to 2 weeks in the hospital. However, we've all seen the stories of those patients who've been in the hospital for weeks and do subsequently survive and go home. Many of them have some substantial disability when they go home. They need to be in physical medicine or rehabilitation to regain their strength and other things. There was a prominent story published not long ago about a lady who was in the hospital for 77 days before she went home. So certainly there are long-term hospitalizations that do happen. They're not real common, and those patients then subsequently survive, but they often have some substantial disability at the time they're discharged.
Okay, Corey at the Tulsa World wanted to talk a little bit about the different regions of the state that maybe are having more cases, or and how that's looking. And you touched on it a little bit because you did mention that obviously we have more in the big cities, but that's because we have more people.
Yeah, so we certainly, in our metropolitan areas of Oklahoma, have the most cases that get reported each day. So pretty much consistently, except for outbreak circumstances, Oklahoma County, Tulsa County, Cleveland County have the most new cases on a daily basis, but those are our most populous counties in the state. But when you look at the population incidence, the number of cases per 100,000 population, what we see now is that if you encounter a person in many rural counties, you're actually more likely to encounter a person who has had COVID-19, just because we've seen movement of this disease, this infection, into the rural counties of our state. So they don't obviously have populations that are as large as our metro counties, so they don't see the big numbers of cases. But remember, in many rural communities, the hospital doesn't have the capability or capacity to take care of some of the patients who might have severe complications of this particular disease. So we do see movement of patients who, particularly sick patients, that get moved from rural facilities into larger facilities that have the ability to do long-term mechanical ventilation, to give remdesivir, to do ECMO, should it be required if somebody is really severely ill. So when you look at the number of hospitalizations, obviously Oklahoma County and Tulsa County have the most. If you look at the greater Oklahoma City metro area, which includes Oklahoma County, Cleveland County, and Canadian County, we have a lot of patients with COVID in the hospital. I think more than 200 right now. I don't know the total number of ICU patients at this point.
Okay, and he was asking also about that, about kind of just there isn't really a good source for the number of ICU beds in the state and what's available, so you don't really have anything like that, or?
I don't have that. So the hospitals do capture some of the information and report it to the state health department on a daily basis. I don't think the health department gets 100% of the data each day, but there is no transparent, obvious daily source of number of hospital beds, number of ICU beds. And I think that makes it difficult as we think if we see outbreaks of the disease or we see a big influx of influenza cases, makes it a bit more difficult to know where there may be capacity to move patients. And I think the other thing that patients and their families may not understand, that if we get to that point of capacity issues, it may mean that a loved one, and it might not be a COVID patient, it might be a person who's in the hospital for something more routine, might get moved to another community because of capacity issues if we start hitting those numbers. So yes, there's bed capacity in Oklahoma, but it may mean if we get more cases, the patients have to move, and you may end up even getting moved out of your own community for beds. And I think it's likely that severely ill COVID patients obviously are not going to be moved out into smaller or regional facilities, but routine illness that might be in the hospital, those patients might have to be moved if there was a surge capacity problem.
Well, and that sort of leads to what Austin at K4 was asking about. If the ICU beds are being taken up, how does that look for regular patients, who might have a heart attack or be in a car accident? So that's kind of that's really what you're talking about right there.
Well, to a certain extent, but I want to highlight, if you have symptoms of a heart attack or a stroke or anything, please call 911 immediately. Do not delay because of COVID, because the hospitals stand ready to take care of you. The emergency rooms will take care of you, provide the emergent care you need. So if you have any routine medical conditions where you're concerned about your life, your safety, call 911 and please go to the hospital. The emergency medical system in Oklahoma has already been used to taking patients to hospitals that have the capacity to. So in the Oklahoma City metropolitan area, if a hospital has no ICU beds, or if their ER is overrun or they don't have any open operating rooms, they go on divert. And our ambulance system is aware of that, and they have a system to then divert the patient to other facilities. So you may not go to the one that you first thought you were, but that's been in place for many, many years, that the ambulances have to be prepared to take patients to facilities that have capacity to take care of the condition.
All right, and in the past, let's see, this is a new one, so let me read it real quick. In the past several weeks, we've been on the rise in hospitalizations and continued spread of virus on college campuses. In your opinion, are those two things connected directly or indirectly?
Well, I can only speak for the University of Oklahoma because I look at our data there every single day. And when students moved back on campus, we did see a slow but a definite increase in the number of cases of COVID-19 in the county, in Cleveland County. The same thing was seen in Payne County, by the way. When we look at the onset of disease, you can very much see that there was an increase in activity. But in both Cleveland County, where the OU Norman campus is, and in Payne County, where the OSU campus is, there was fairly substantial drop-off in new cases fairly quickly. So I watch Norman, the city of Norman, I watch Cleveland County, I watch the zip codes that are right around the Norman campus. I look at all of the data that we collect from the Student Health Center on campus. And the other thing that we're doing in Norman is looking at, on that campus is looking at wastewater, how much COVID-19 is found in wastewater, the sewage that comes out of the buildings and things on campus. And the good news is that all of those sources show that those cases have come down fairly substantially. And if you look, again, if you look at the population incidence of COVID-19 in Cleveland County, there are fewer cases per 100,000 than there are in many other rural parts of the state, and just below the statewide average right now for cases. So we've been watching it very carefully because we were very concerned about that. We didn't want reopening the college campus to also cause an adverse impact on the community, the county, and although there was some increase in cases, that has been steadily coming down.
All right, this may be the last one. Thanksgiving is next month. What impacts do you think the holiday would have on college campuses, and what advice do you have for anyone who's traveling?
Well, I think as most probably know by now, both OU and OSU and other colleges in our state announced that we will go online for the remainder of the fall semester after the Thanksgiving break, so that students who elect to go home, they won't have to come back to campus. They can do their online education from home if they want to. And that's primarily to reduce the concerns about transmission of the virus for people who are in transit, whether it's by air or car, going to other communities. And I'll just, again, using the OU campus in Norman as an example, we have a mask mandate in all OU facilities. Norman has had a mask mandate for a long time, one of the first in the state. And so we actually see very low transmission of the virus in that area at this time, but we know many students may be traveling to parts of either our state or other states that don't have mask mandates, that have higher population incidences of COVID-19 than Norman does, and so we just didn't want to have to deal with bringing those students back and potentially increasing the risk. One thing we have done in Norman is we've encouraged our students who are going home for Thanksgiving to come and get a free test before they go, and not to take COVID-19 home to their families. And that's a free service that's available on the Norman campus. I think all of us expect that with gatherings, family gatherings, we know that family gatherings actually do result in an increased number of cases. And so it won't surprise me if we see some uptick in the number of cases a couple of weeks after Thanksgiving.
Okay. Anything else?
It's flu season. Make sure you have your flu shot.